waiting on a few. Sorry, I'm Sorry, I unmuted on the wrong device. I was just saying we're still waiting on a few other members, so I'm just going to give it a couple minutes, and then we should be able to get started. Just double checking. I see a Mallory on, but I just wanted to check. Is that Mallory Shaughnessy? Or maybe she's not in the she can. Well, that's what I wasn't expecting, but I just want to make sure she was on. Okay. Okay, well, since it's 5 after, why don't we go ahead and get started? Back again, there we go. So welcome everyone to our latest meeting of the Advisory Council on Affordable Healthcare. Thank you, Heather. Great to have everybody together again. Apologies for the disruption in December with that meeting, and I know it was a lot of last minute changes trying to kind of adjust to everyone recovering from the storm and trying to manage that day. So glad to be back together again, and hope that we didn't miss too much. I know I had shared a draft of the annual report and outline of the public option report, so it was great to get a few comments back from folks on those. And now we are in the midst of a new legislative session, so I have to say it feels like time has flown by to me. I was just saying to members in the room that it doesn't feel like 4 months, and certainly time is moving quickly in 2024. So excited to dive into today's agenda. Oh, I can run through attendance, I guess, quickly, although I'm going to try and do it with my my list in front of me. So I guess we can just go around the room maybe quickly and shout out the members of the Advisory Council. So Kate. Kate Envy, She/Her, with Consumers for Affordable Healthcare. Trevor.
I'm Trevor Putnocki with the Healthcare Purchaser Alliance.
Jordan Rhodes, Maine DHHS.
Heather Crowe with Maine Department of Administrative.
Okay.
Kevin Rose, Community Health Options.
Thank you. And Katie, do you want the next line?
Sure. Katie Fulham Harris, Maine Health.
Perfect. And Zach?
Jeff Sanford, Northern Light Health.
Perfect. And Renee, I see your message. I'm going to give you access right now. Just give me 1 second. Okay, Renee, you should be able to come off mute now. Sorry about that.
Yes, thank you. Hi, it's Renee Fay LeBlanc. I'm internal medicine doc working at Greater Portland Health.
Great, perfect. Thanks all. So we've got a good representation today. I know there were a few folks with conflicts, either pre-existing or related to the legislature. I know right now is a tough time to have meetings really at any time, any day. So great to see you all here. Thanks for being here. The rest of our agenda is to give a quick update on some administrative activities and a couple brief sort of significant activities in the legislature that I just wanted to note for the group, and then sort of the meat of today's meeting focused on analytics updates, including I'm really excited to have a kind of a report back from a first phase of some of that work with the Urban Institute on insurance enrollment and costs, and then a little bit of a discussion on what comes next in the spending category. And then just some next steps and closing feedback. So moving into the admin items, I'm excited. I feel like I have lots of good news to share today. The first of that, I know I shared back in December related to the meeting, but just wanted to give a reminder that there is a website now for the Office of Affordable Healthcare. The URL is here on the slide. Encourage folks to visit there, keeping that updated with information about meetings and also meeting records when we finish them. There's a page now with records of the public hearing, so all the written comment that was submitted is live there, as well as a recording of that meeting and the slides that were used. So really excited to have that as a conduit for communication and encourage everyone to use it as much as possible. The one thing I've heard is some folks Googling, it's not quite showing up yet. I think we have to work on our search engine optimization or something, but the more I think that folks, can use it, the more it'll hopefully get noticed, and please, share that with anyone who may be interested. Related to that, but also very exciting, is an update on the senior analyst position. That is now posted after a little bit of work getting the correct closing date. It's ready to sort of be circulated, so that is closing on the 16th of this month. Would really appreciate help in promoting that. We'll say that to members of the advisory council, but also others who are watching today. Please, if you know anyone who might be interested in that position, share that with them. Really optimistic and hopeful to find a good candidate for that role, which I think I've noted before is really very quantitative in focus, somebody who can help to lead some of this analytics work and sort of complement my skill set, since being a data analyst myself is not my strongest suit. So really excited about that. Also wanted to just flag again that there's fellowship information posted. So I was able to secure some funding in my budget to be able to pay for fellows looking specifically for graduate students who may be really recent graduates looking to get a little bit more experience under their belt. Those positions are very flexible. They can be totally remote, so it doesn't need to be necessarily a student based here in Maine. And I'm really looking to kind of work with students that have an interest and hopefully foster interest that they already have, give them a chance to dig in. So it's also flexible in terms of kind of timing and focus. So both those roles are now up on a Work with OAHC page on the website. And again, would appreciate any help in circulating them. And hopefully by the next time we meet, there's an update on that senior analyst hiring. I wanted to flag as well, I know members of the advisory council, I noted this via email, but that we made a change the remainder of the meeting schedule because it was flagged that this Tuesday time conflicts with the MaineCare Advisory Council, which is a standing and significant conflict that we wanted to avoid moving forward. So after doing a quick poll, there was one day that was identified, the first Wednesday of the month in the afternoon from 2:30 to 4:30 when all members who responded were able to attend. So I'll be updating the website shortly with those dates, but wanted to make sure to put just an extra emphasis on that as well. And last one, I can pause for a minute, policy forum plan. So I know in the fall, we had talked about trying to put together sort of a one-day event for members of the advisory council and legislators. Ran into several logistical challenges with that, and then I think some external events too made it especially difficult to pull together. So decided to sort of hit pause and revisit that idea. and wanted to come back to this group with a little bit of a new thought about how to structure that moving forward. I think something I have been struggling with too is initially I thought, well, we can do it in 2024, but I think obviously right now legislators in particular, I think, but I also know many members of the advisory council are really busy with legislative activity, and that carving out both the actual time and the sort of mental bandwidth to be thinking more about big ideas in the future might be challenging right now. And then also, purely sort of logistically as well. Obviously, there's an election coming up in the fall. We expect there may be some turnover in members of the legislature and certainly maybe different committee members, and want to be thoughtful about, if we're going to spend a lot of time thinking about policy ideas and sort of laying groundwork there, making sure that we're doing that in a way that's like looking to the future and inclusive of folks who may be interested in the long term. So wanted to propose a little bit of a different approach. I was thinking about using some of our advisory council time potentially at the next meeting to invite in some guest speakers. So definitely a scaled down version, not like a full day, but thinking about using some of that time to hear from other states, which was a big part of the goal of that event in the first place. To some extent about their policy initiatives, but I think really interesting to invite them to talk about process too, like how did you land on the initiatives that you're implementing and kind of what was your policy development process and how did you set priorities for your state? Because I think there's a few states that are doing several different things in the affordability space and I think could be interesting to hear from. So thinking about doing that as an initial step, and I think realistically, probably the advisory council would be the main audience, but we could make an extra effort to invite legislators to either join us live or watch those sessions. And then thinking more about kind of the fall timeline as a time to maybe revisit more of a structured gathering all together, and maybe doing that sort of through the legislative structure. I think another challenge is just running into, how to make sure that we're complying with all the meeting requirements that we need to in public access. And so doing that in a little bit more of kind of a collaborative way with the legislature may help. So that's maybe the most substantive item on this list. So I will pause there for either questions on any of these items, but especially if there's feedback on that, thinking about how to manage kind of that forum structure.
Sounds good.
Great. Wonderful. Moving on to a couple of legislative updates. So I just wanted to highlight a couple of things that, as I said, felt pretty significant in terms of the office's involvement with the legislature. The first of those is that the task force to evaluate the impact of facility fees on patients, of which both Kate and I were members, has put out a report back to the HCIFS committee, and actually later this afternoon, I think they're having a session to discuss those recommendations. There's a couple mentions of the Office of Affordable Healthcare in the recommendations from the task force. One is working with MHDO on reviewing their data collection and their reporting. When they had that out, I don't believe that their report has been released yet. But then in particular, there is also this potential recommendation that the office review laws in other states and discuss and sort of report back on whether similar limitations, prohibitions would have an impact on the cost of care for consumers in Maine. I definitely will say, I think, in the course of the task force, which was also very compressed. We just had 3 meetings over like a week and a half, 2 weeks, 3 weeks maybe, but moving very quickly. I think there were some questions left open around definitions of facility fee, really getting into the weeds of exactly what codes are we talking about and billing structure. So there were kind of some big, fairly big open questions I think left. So this may be coming my way. I did express to members of that task force that assuming and sort of trying to be considerate of maybe other requests in the longer term, that I think that this is something that the office would be capable of doing and could absorb on sort of the rest of 2024 timeline. It's an issue that I've dug in on for the task force, so I think that it's something we could do, but just wanted to kind of flag that because it is a little bit of a new kind of requirement or mandate coming the office's way.
Can I ask a question about that,
Yeah.
Bill? And this may be a stupid question, but if this like a ban on facility fees passes, does it prevent hospitals from being able to bill facility fees to Medicare? Or is it really just in the commercial market, the fully insured market?
I would say it would just be in the commercial market. There was some conversation, I think, about whether you make that explicit in the legislation or not. I can speak for myself and say my recommendation would be to do that. I don't think that we can sort of preempt Medicare payment policies with state
Yeah,
laws.
that's what I was thinking as well. Maybe you know this better, Katie. But my understanding was that there was a pretty substantial loss the hospitals were projecting as a result of this bill, which I'm assuming would be on the Medicare side, because we don't really see very many facility fees on the commercial side.
Yes, if I may.
Yeah, sorry, Katie. I was looking at you expectantly and then I realized, oh, you can't see me, so please go ahead.
And sorry, I'm not there in person. The recommendation that was supported by the majority of the task force was to support the NASHB model legislation, which prohibits the billing of facility fees or E&M codes for outpatient services provided on hospital campuses and includes Medicare. So it's all payers except Medicaid. Which was included. So the NASHB model legislation includes Medicare, which requires us to bill on a facility fee or on that portion to split the professional side and the facility fee side. So Trevor, you're absolutely right. And it has been one of our biggest frustrations that the task force failed to recognize that Maine's law already addresses facility fees for in the commercial market. And we'd be happy to, if that law needs to be tweaked, that's something different than what has been proposed and voted on and is going to be discussed by the committee today.
Okay, thank you. I appreciate that. This is a point of real confusion for me, as I don't understand how you could prevent hospitals from billing Medicare with state law. But
Yeah,
someone can explain that to me in
I
some
think
way.
you can't change how Medicare would cover it, but I think if the
It's something
requirement on
generating
the
revenue.
provider, and I believe Connecticut might have done that. I felt
No one has adopted a prohibition on billing Medicare.
Yeah, okay.
I think
don't
I
want to get
think I
sidetracked
would
here.
it's a
Very
big
conflicting.
question, and I am not the authority. I have thought about it the same way that you have. I think, Trevor, that if it's not explicit in the legislation, I would have thought it was assumed. I would imagine that this is something that Colleen will be asked maybe this afternoon, and that Colleen, the committee might look to Colleen to provide clarification of that and make changes. But I hear you too on that question of if they are exempted, then it presumably changes the sort of impact pretty significantly if, as I think we heard in the task force, that law that we have on the books today related to the use of standard claims forms, seems to be addressing a lot of the cases that do exist in other states. So it's an interesting topic and a weedy one, and I wish we had more time to sort of iterate on that in a task force process. But I mean, it does make me look forward to, the opportunity to kind of take a step back and comprehensively take a look at this in this reporting requirement. Should it be finalized, my understanding is, the committee would need to kind of vote to actually take action and memorialize, I guess, that recommendation from the task force. So then moving on, there was also an amendment to LD 1829. I don't have the title right in front of me, but that was a bill that was introduced last year by Senator Rennie to create a program to reference prices for drugs to the Medicare rates negotiated under the new authority that Medicare has. That bill was changed and sort of now addresses the Prescription Drug Affordability Board, the PDAB, which my office and I are directed to provide staffing support to. And initially, the amendment sort of changed the scope of the PDAB to take a look at a wide variety of models to both directly potentially address the price of drugs and also models that could provide more essentially protection to consumers from high drug prices. And I had worked with board members and the sponsor on that, just helping with thoughts on legislative language. There was a change to that sort of pretty late in the process and definitely in the course of several meetings and a lot of time pressure on the committee that added in a requirement for the PDAB to actually establish a methodology for setting upper payment limits for drugs and then sort of a rulemaking path forward to actually implement that policy. Since that is definitely assessing what that means for the office in terms of its staff, its support role to the PDAB, and what that would mean for resources and expectations, since that is a heavy lift for sure. So I did just want to flag it and kind of make members here aware of that, although not sure of the final outcome of that bill, but obviously something that I'm keeping an eye on and involved in.
Is there recognition that unless it's applied at the manufacturer level, this does actually nothing, and in fact increases premium costs?
I don't know if I can answer if there's recognition of that. I think I have shared, that I think there is a lot of policy work to do, especially around issues like how the payment limit would be passed up the supply chain, because we know we can't actually enforce it at a pharmaceutical manufacturer level. So, I have my, questions about that and how it would work in practice. And, I think have tried to flag that this is something some other states have passed, but has not been implemented at this stage. But in terms of, when you say, is there recognition, if you mean by members of the committee, I just, I can't answer. I think it would have to be directed to them. That I will say was sort of part of the interest in shifting that group's role. I should have said, by the way, that the structure of the PDAB now is very specific to public payers. So they're supposed to set spending targets and then monitor and make recommendations, but they're non-binding spending targets. And there was just a sense among that group that, they're really interested in affordability for other consumers. And I think some challenges too, like recognizing the complexity of contracting for public payers, that it's not, an easy, like, oh, here's an idea, run with it. So I see value in a group that can discuss those issues. And I think I had it on the agenda to talk to this group about, because I see there being a forum certainly for talking about prescription drug prices in this group, but there's so much complexity in that area and certain expertise. There's pharmacy representation on that group that I think it would be valuable to sort of be able to have conversations and dig into some of those details in a way that's not just a hearing and then a work session and kind of moving in that quick succession of the legislature. But part of my interest in that was to talk about like what does implementation look like for some of these ideas. So that's why I do want to say that the change to this implementation and methodology development was something that wasn't initiated by my office. We weren't involved in that conversation. Yeah, I'm sure more to come. And I will say, there's other issues I know moving through the legislature right now that I'm kind of keeping tabs on, but these ones felt like the two issues where there's kind of direct impact on the office. And with this short session, I will say, and I'm sure others in the room feel this too, that right now it can be hard to even keep tabs if you're not like right in, because things are moving so quickly and changing so quickly. So by and large, I've been in a little bit of a monitor and be available if folks have questions or things they want to run by me, but kind of not trying to be involved in every single bill, because I think I would just be over at the cross building most days.
Have they asked you about 1165 at all, the point of sale rebate bill? That's the one we're particularly concerned about, not only because of the impact on premium, but you basically are giving as strong an incentive as possible for people to use the highest cost drugs. So I think it's going to yield some pretty large cost increases across the market.
Yeah, I haven't been asked. I was just going to turn and say if there's other issues that members want to discuss. I think in thinking about working with the legislature, tricky, because I know folks have sort of their day job involvement, and then there's the advisory council. I say that only because, I'm open to and interested in the role like the advisory council would potentially want to play if there are issues where you feel like there's a voice to speak on issues of affordability for consumers. But no, that could be tricky territory, again, especially because things are moving so quickly that it's not like we have a lot of time to sit and assess together. So I have seen that one. I took a look, and I do feel like that is an area that the Bureau of Insurance, typically has kind of jurisdiction over, and would speak to how mandates or changes in coverage structure impact premiums. So I haven't sort of tried to step in on that or other mandates, but definitely, watch that work session and have been keeping an eye on it.
Yeah, there seems to be a lot of confusion among committee members there.
Increase premiums by
1 to 2%. Oh, well, with the amendment, it's 1 to 2% now. But still, I mean, that's on top of all the other things that are going to contribute to increased premium. It's a lot.
Yeah, I think difficult sometimes to communicate that, I know, especially when it's like a lot of different bills and trying to understand how at large, changes are gonna impact premium. So I know I've been in the position of sort of, raising that before. Again, I've taken a little bit more of a backseat on that one just because there are so many bills, I think, with somewhat similar rationales kind of moving right now, but yeah. Okay, any other questions on this? Items? I will move us along then. Oh, sorry, I have a little delay. So jumping into kind of a section of the conversation about analytics and our next steps there. I think, Katie, you had asked for this conversation about defining terminology, so I wanted to revisit this question. And I took a look around. I knew I'd seen something, and there's a great piece, which I recommend if others are interested in just mulling this over, from Health Affairs Forefront by Erin C. Brown about the whole issue of terminology. And I think one thing that I will acknowledge from that piece, it is that there isn't consistency and a lot of clarity on these terms. So to the extent that we have moments where we're saying, well, what do you mean by cost? We're not alone in that. And as much as I want to talk about definitions, and I think I keep saying work on my own sort of commitment to trying to be consistent in the terms that I'm using, I think we also need to acknowledge that to the extent we're looking at external work products or reading articles, others will use these terms at times interchangeably. So just sort of seeing that as a baseline. But that being said, I did want to walk through, I think, kind of the three terms that have maybe, tripped us up or where we've had those questions in the past, and just think about how we're using them and trying to be consistent with that. So the first of those is spending. Healthcare spending, I think that term itself generally describes the total amount that all purchasers spend on healthcare. So purchasers including employer-sponsored plans, individual households, taxpayers, government. We use that term with the CMS reporting on total health expenditures nationally, that really it is kind of this comprehensive overview of spending. I should have flagged in here, and this is something Trish had flagged for me after looking at the slide, so a thank you to her on this. I kind of excluded spending on the part of consumers and purchasers from this definition, but obviously I think there are times when we're going to use that too. So every time we say spending, I don't think we necessarily mean national health expenditures, but trying to think about whichever context that is in, that spending is still the total sort of payments, total expenses on behalf of whatever level of purchasers we're thinking about, anything up from that really macro level of national or macro state level down to an individual purchaser. Prices is one that I wanted to especially spend a second on. So I think Erin's article and in general, looking at this from the kind of policy and economic side, generally that price in these conversations refers to the total amount a healthcare provider supplier requires as payment for a healthcare item or service. I know that's different than maybe our colleagues on the provider side who may use price to refer to list prices or charge prices. But I think when we're having these conversations, this is one where I wanted to say, I think unless we specifically say list prices, we should generally be able to assume that if we're referring to prices, we're really meaning, what is paid to the provider for the services or items that they're providing. And then I'll just go to cost quickly and then we can pause, because this is definitely one of those slides that's meant to spark discussion, not necessarily be definitive. But In terms of costs, this is another one where I know we've gone back and forth a little bit. I think that we can use healthcare costs or provider costs to refer to input costs of providing medical services. I know that's important to have a terminology to talk about what do we mean and what are we referring to and what are the actual costs of providing the care. So, noted here, labor, overhead, energy, all those input costs. But I do just want to acknowledge, because I don't know that we're always going to be completely consistent in only ever using cost to refer to those input costs. It is really typical, and I think to some extent, even in the establishing legislation for the office, to use costs kind of interchangeably with spending when we're referring to purchasers and consumers. And I would actually argue, in some ways, and I think Trish kind of made this point potentially in her note too, but it was something I was already thinking about. I know that I sometimes lean towards the use of cost for consumers, because I think that there is a little bit of an implicit meaning there that, there's not a lot of control. Sometimes saying like consumer spending on healthcare sounds like they have a lot of ability to determine what their spending is and almost more agency. Whereas, often we know, not in all cases, but in many cases, these are costs that consumers don't have a lot of ability to control or make decisions about. So I know it's not, a perfect, clean set of definitions and a complete commitment that we will only ever use one term, but I thought that this might be helpful as a starting point for these conversations, and particularly, I think, in terms of price and cost, talking about a default meaning for those terms, and sort of committing that if we are using them in different contexts, that we'll kind of make sure that that's clear through contextual clues or extra terminology. Yeah, Katie, please go ahead.
Thank you. First, I want to thank you for taking this stab at trying to define this, because I think it's very helpful. And there are big chunks missing here for me, which include insurance and pharmaceuticals specifically. And maybe they're intended to be built into this, but when you think about cost, or the way that people define cost personally, those are big items. So it's not just or provider costs, or it's not just spending. It's got broader than that. And I guess I'm curious as to, Karen Hughes Brown is someone who hospitals have a lot of disagreements with. So I say that not as anything other than to point out that I think there are some gaps here.
Yeah, to maybe take a step, I guess I want to understand, because it sounds like maybe two different issues to me. I did adapt this from her language, so maybe coming from her saying provider, I would kind of, we could expand that to say providers, manufacturers. I sort of mean that to be any actor in the healthcare delivery system that's providing a good or service to consumer. And I think that there is some overlap there in terms of, for example, price. When I'm referring to pharmaceuticals, I also don't necessarily mean a list price, really trying to mean what does that mean for the consumer and the payer combined. So I'm thinking that one's, a little bit of an easier fix and a welcome flag, Katie, to, either be more explicit when we're talking about bread or use some different terminology there. But I do want to make sure I'm not missing anything on that side. And then maybe to me, it's a slightly different question, the question of what are consumers thinking about in terms of costs, whether you just mean, that it's not only medical services they're receiving from a hospital or provider, it's also their drug costs. I mean, I totally agree with that, but I just want to understand if that's also related to kind of that terminology and inclusiveness question, or if there's other costs or other spending on behalf of consumers that you think is not captured here.
Well, so the middlemen in the system, which add to cost, are not captured here as I see it, whether it be insurers or PBMs. So I'm seeing the input costs, which I think is really important, related to labor, overhead, those things we experience as providers every day. But from an employer perspective, it looks like there are pieces missing that I don't see captured.
Yeah, I think, I haven't tried here, I guess, to be hyper specific about all of the different elements that develop or go into what a consumer is spending in total. I do think that that's another level down from these definitions and maybe gets a bit beyond the definitional concept. I think that potentially overhead involved in insurance, consumers feel that in the sense of the cost of their premium, and theoretically, if there is, more overhead, that's having an impact. So I guess I hear your point, but I'm not sure I can see where that would be incorporated into the terminology here, because I do think the way that we would define spending on behalf of consumers, whether that be either an individual or a business, would incorporate any of those costs. Anything, it is whatever is coming out of their pocket, regardless of what the drivers of that spending are, if that makes sense.
I appreciate that on the spending side, and I guess on the cost side, I'm not sure why we're limiting it to the input costs that providers experience as opposed to the input costs within the system as a whole that then translate into what consumers pay.
I think that we can. I have to say a little bit surprised. I think that it is helpful to define from a provider sense what input costs are, in terms of being able to define what are the cost of services. That's sort of like an important building block to thinking about affordability writ large, because actually I think it contributes right to that conversation of, if you know exactly what it costs to provide in a world where you can understand exactly what it costs to provide medical care, being able to identify that actually I think helps with the question of, okay, if that's what it costs to provide the care, then why is a consumer paying more? And if the answer there is costs of insurance administration, I think that actually makes that easier to understand. I hear you, but to me, I thought that this was helpful in terms of being able to separate out sort of input costs on the actual provision of care side. So I'm not saying it to say that there's a relationship between those two things. Maybe that's what's helpful to draw out, that healthcare costs and or provider costs don't have a direct relationship necessarily to the consumer costs, just that there are two different ways of kind of using the terminology in the conversation.
That's fair. And then I would ask what you mean here, because you say that they're used interchangeably with spending. So that's what's getting me.
So I was really just meaning the word cost is often used interchangeably with spending, that it's really common, I think, for people to say, we're worried about healthcare costs. And what they mean is not necessarily we are worried about the input costs of providing healthcare. What people often mean when they say that is, we're worried about what people are paying for healthcare. So they're really, and maybe I should have made this clearer, two different ways of using the word. And what I was trying to express here is that I think we can sort of agree, and again, I'm going to try to hold myself to this, but I know we might slip up to, like, when we talk about costs in this group, that we're really meaning input costs, so that we know when we say cost, that's what we're referring to, and that generally we would try to use spending as a way of talking about what's coming out of consumers' pockets. But I just wanted to acknowledge this because, again, so many papers that you see, so many, often, certainly I think if you're over in the legislature, people are going to use cost to refer to consumer spending, and I don't think we can completely control for that. So I was just trying to sort of mean, that we'll see that pop up, and hopefully, again, with context, or I can certainly try, at least if I'm using cost, to say consumer costs, purchaser costs, to differentiate that.
Just in terms of our discussion, so we can kind of get on the same page about what we're talking about.
So yeah, and I apologize for that, Katie, and not sort of making that clearer in that bullet, that I wasn't trying to say healthcare costs, provider costs are interchangeable with costs for consumers, just that the word cost is used in both those. So I kind of
I appreciate that, and I guess as a member of this committee, I would ask that we clarify that if we're going to be using these definitions and sharing them more broadly beyond this group.
Sure. Yep. Happy to do that. maybe I can make a quick edit and we can like briefly revisit at the next meeting. And again, I just acknowledging that I don't think we'll ever reach total sort of perfection on this, but it is hopefully helpful so that we don't have to kind of get tripped up or, you know, have the conversations as we're trying to discuss sort of substantive issues here. So were there any other comments, thoughts on this? Great, so moving along, wanted to give a quick preview of a report and some work done by the Urban Institute on behalf of my office, our office, that I'm excited about. It ties into one of the sort of policy and other analysis agenda items that I had flagged in terms of trying to get a better feel for both enrollment in coverage, given the impact that has on affordability for consumers, and then actual spending for consumers and what that looks like across some different demographics. So worked with the Urban Institute and their health insurance policy simulation model. It's a microsimulation model of the healthcare system that estimates cost and coverage effects of proposed healthcare policy options. Really was designed to be able to model out different policy ideas at both the national and state levels. This is drastically oversimplified, but its basis is data from the American Community Survey conducted by the Census Bureau, though it incorporates in more timely sources of data for some inputs. So Medicaid enrollment, marketplace enrollment have been incorporated in from state data sources in the case of this modeling exercise. So we were able to help connect them with the latest sources of data on that. Exceeds my knowledge significantly. So I included a link to the full methodology, and I'm sure people like Jordan understand this much better than I do, but you know, they apply a wide variety of different assumptions about consumer behavior to their modeling to really understand, you know, in a world in which options change in certain ways, how do consumers respond to that at both the individual and the business level. And I will say, I mean, this model is one I've been familiar with for quite a while. It's like one of the premier models for health policy modeling. So very nerdy, from a very nerdy perspective, I'm excited that it's updated from Mean. And the report out that I'm going to share today is really a baseline report. It's a projection of what health insurance would look like in Mean in 2025, assuming current law, both the federal and state level. One quick caveat on that that's a significant one in the individual market side is that that's the final year of the current additional subsidies that are available through the individual market. So this does assume, you know, those subsidies because it's looking at 2025, although I think the landscape could change a little bit in 26 and beyond if those are not continued. So a quick flag there, but another important aspect is that it does project out, you know, past the end of the Medicaid unwinding, mean care unwinding process, which is, you know, the resumption of kind of regular eligibility checks for mean care members. I think that is all. Oh, the quick thing I was going to say is this report is that baseline. It does mean that the model is updated, so it can be available now for modeling out of policy options in the future, but that's sort of a bonus. This was a way of helping us to just get an eye to what things will look like in a year or so. So moving through, it's a little bit small, but I just wanted to give a quick view of health coverage for the non-elderly. I will also flag throughout this analysis, it focuses on the quote unquote non-elderly population, essentially the population too young to qualify for Medicare. So just a flag there when you're looking at totals to give that context, because it does change how things look a little bit, but you know, excludes that because of the role of federal policy there, as well as relatively high insurance rates and stability in that market. So a couple things to kind of flag here. I think a big one being, you know, projections, unsurprisingly, of some significant movement into the individual market following the end of that mean care unwinding process. I think these projections may be a little on the high side relative to maybe expectations that the Department of Health and Human Services have taken a look at. This is definitely a new area. There's only a few states working on this, and there's very drastically, I think, different policy outcomes based on the way that states are approaching that process. And I think to date, it's been, quite a careful approach, I would say, here in Maine versus some of the states that went early and were very aggressive in moving people out of coverage. So I only want to note that because, it's a different way of projecting, and these are all estimates, but that I would say is the most significant factor here is that reduction in Medicaid and CHIP, and then movement into the marketplace, both with PTC and some full pay members as well.
What is that? I'm sorry.
Oh, no, I shouldn't say. I got a question. So is the traditional non-disabled adult, is that parents? That's broken out separately from expansion?
Yeah.
Okay.
Did you have a question, Heather? And then Kevin.
I was having a hard time making the totals make sense. On the bottom.
Because of the size of the population? Versus
Well, it says total 1,025,000, but you've got 965 and 561, and are we adding up the whole column? Because it doesn't add to 1,025,000.
Oh, that's a good.
Because it could be some people have duplicate coverage.
Yeah, so that's
Yeah,
what,
I was wondering if there were some subtotals in there that I wasn't understanding.
yeah, so it's just would be insured plus uninsured. So that entire insured population, all the employer Medicaid CHIP are all adding up into that insured population. Thank you. I just have a brief moment. But yeah, that's why it's real. The total is really just the combination of those two categories.
Thank you.
Do you know offhand what the full pay of, the marketplace with PTC is today? After open enrollment, net of people who did actually matriculated the coverage?
I do not. Last year, I would have had that answer for you.
Yeah, I know. I just wondered if you still have that. So I'm thinking it's around 61 and change, but that was from a couple of weeks ago, so I don't know what that was.
That's what I was gonna say. I know that was the final plan selections, but with attrition, and then separating out the full pay versus subsidized. I'm just not sure off the top of my head.
Do you know when we can get that?
Yeah, I can check in. I don't, I'm trying to remember when we released that. Definitely in the spring sometime. I think that comes out in Marketplace public use files, but I'm happy to do some checking in and see if there's a category. I was like, hey, can you project for us, Kevin? You must know attrition.
It changes though year to year depending on what's going on.
Yeah. And so would other non-group just be off marketplace plans?
Yeah, it's a good question, and this is one I've actually struggled with a little bit. It's not super well defined, I think, in part because the ACS data is coming from survey responses, and so it's hard to be like, what do you mean with this coverage? Because I have questioned the size of that group a little bit. It could be non-compliant, so short-term limited duration plans and other states, that would be an expectation, but that doesn't really match with my understanding from conversations with the Bureau about uptake here. Essentially, my understanding is those plans aren't available in Maine. I think that there could be consumers who were thinking about, the other non-group.
Oh, other non-group.
So it definitely would be off marketplace. But to the extent that it includes other forms of non-compliant coverage, actually,
It could be like cost sharing ministry.
yeah, or fixed indemnity. That's the one type that I have heard some issues with consumer enrollment in, and that's where I'm working on sort of getting a better understanding of that myself. And whether they're considering that uninsured or insured in this category. I've seen in some of the other tables, which I didn't include for today because I just wanted to do a preview. They do specifically refer to that category. And when I asked about definition, they were sort of like, we also provide one. So it's dependent on responses, but
That's how people interpret their coverage.
Yeah.
Okay, that's helpful.
Like, it'd be interesting to see the like the baseline year? I don't know if that's available. What is it, 2022 data that they generally use?
I think it's a little bit older for ACS just because of data availability, but then the Medicaid Marketplace enrollment was from end of 23 actually.
Yeah, well, that's really available, just like kind of putting them up against like the projections to see how, both the population figures and the percentage changes.
Yeah, I think anytime there's a projection, it would be helpful to have
Yeah.
baseline to see where our trend is.
Yeah, I'm happy to do that. These kind of came to me. We really just finalized like in the last few days. So I haven't had a chance to like do any of that work myself. So I'm kind of doing it off the top of my head. But yeah, I'm happy to.
I'm surprised by the full pay marketplace.
Does that seem low to you?
Well, I think it's, what is it, 8 out of 10, more than 8 out of 10 usually qualify for a subsidy. So I guess I haven't really done all the math, but.
That's both, I would assume that's both people on exchange without APTC and also people that are enrolling off exchange.
Got it, okay.
But you could validate that.
Yeah, I'll take that question back to them about the full paid marketplace versus other non-group.
Yeah.
And try to understand that one a little bit better. This I will say is part of why, I wanted to share. It's not a finished work product. But,
No, it's still very helpful.
stuff
It's
that,
very interesting to see.
Yeah. So then a few slides on uninsurance rates. The first here by income group. Not shocking. Oh, I'm sorry. Did you have a comment or question, Katie? Okay. Just the significance of that kind of decline in rate of uninsurance as we go up the income scale. It doesn't always necessarily translate to total numbers. The sizes of these populations vary a little bit as well. So we do have those numbers, but not right in front of me. But significantly higher rate of uninsurance among that mostly Medicaid eligible population, with that 138 to 200 FPL being the next closest.
I do have a question, which is, I'm just surprised at the number of people who are uninsured above 400% of the FPL. And that's, does that surprise anybody else? It's almost 50%.
It's still a little high. I've actually been hearing a lot of stories lately though about employees who are opting not to get coverage because they just assume that their health status is fine. They're not going to use it. The cost has become such a burden.
Yeah.
Assuming it's a lot of those folks that just don't feel they're at risk really.
Yeah, I would guess that population and also maybe self-employed too, where they're very exposed to costs, and I think similar logic where maybe you have the income and savings that you sort of feel like, well, if I am unlucky or something comes up, I'd rather sort of like absorb it, then and sort of take the risk. And I'm sorry I can't look at this at the same time since I'm controlling the slides, but I should have the final report in the next week or so and then can share it. My other instinct is, that's that uninsurance rate, it's a smaller population than some of the other income categories too. So not to say that negates, the 4.4%, but that's maybe not comparable to 4.8% in terms of total people in that 200 to 4% FPL.
So this is like 4.4% of the 5% of uninsured population. No.
4.4% of the population that's above 400% of FPL.
Okay.
Yeah, it would be great. It would be great to see the actual numbers on that. Sorry, I jumped it. Apologize.
Yes, sorry about that, Jeff. I should have just layered those on so we could look at them. But again, I'm happy to share this report when we've got it. Renee?
Yeah, so I'm just wondering, do we know for the folks who look like they are eligible based on income for main care, do we have a sense of how many are actually eligible, but they're not accessing main care versus the number that are not eligible?
Yep, actually in like a couple of slides, I've got a little pie chart that talks a bit about eligibility. So I will circle back to that one if that's okay.
I would just ask, if we could layer age, if that's possible, to look at age in relation to any of these splits by income. So above 40%, are we talking mostly younger Mainers? Are we talking mostly older Mainers? Oh, there you go.
It's not quite what you were looking for because it's not layered on top of that income breakout, but this is one that I definitely thought was interesting as well. Again, it's not like it's counter to expectation. You know, there's long been that conversation about the young invincibles who don't sign up for coverage again because they are sort of willing to take the risk or maybe think that they're not going to need it. But I still thought it was sort of staggering to see that, you know, close to 10%.
I'm worried about that 9.2% is probably more mass than the under 200% FPL. And what does that mean for access to care and preventive services and, you know, their kids getting into volatile visits and all of those things that we know accompany lack of coverage.
And the overall health of the market.
Yeah, and I do remember I was looking at the numbers and that I think was around 20,000 individuals kind of in that category. So yeah, this is one that jumped out to me, you know, not to get ahead of ourselves, but like looking at this with that sort of policy lens of, you know, where are parts of the market that could really benefit potentially from intervention, you know, that age group really jumped out. And obviously there's lots of conversation about trying to outreach to them better, and that's one part of the puzzle, but just from trying to think about, you know, where are places where there's a lot of potential essentially to make change in the market in Maine, that's one that jumped out, both from the perspective that Kevin raised of like the need among that group, but it's also one where there's potentially benefits to the market as a whole from having greater enrollment among those folks who are, you know, generally a little bit less likely to be needing medical care and therefore kind of benefit the risk pool. So this is that pie chart I was referring to with Renee's question, just breaking out among the uninsured, only the uninsured, what is their eligibility for public benefits. So you can see about 40% eligible for Medicaid and CHIP, and then another 32% eligible for marketplace PTCs. So I know I said this a lot when I was over at the marketplace, but you know, always did try to make that case about there being a large population of folks who are eligible for help and where we have, you know, opportunity maybe to help connect them to that coverage. Obviously, there is the ineligible category. This is one where I've made an ask and trying to look into whether it'll be possible to do a deeper dive there, because that ineligible category in my mind is really kind of made up of a couple of different populations. There's potentially folks who are income eligible for Medicaid but ineligible because of immigration status. Or similarly marketplace PTC. So I guess I'll say like immigration status as a eligibility challenge, and then potentially a population that may be significant in terms of folks who are ineligible because they are over income for PTCs in the marketplace. And, you know, looking at that distribution, that is going to be a considerable portion of that. And I think understanding that better would be really helpful, because knowing it's 30% is, you know, it's hard to know which of those is the bigger driver and how it breaks out.
I do too, and that's something that I've tried to like find like unsuccessfully. So would love to see that breakdown.
Yeah, I checked in about whether it's possible to have an answer as specific as like what is the reason.
Right.
If not, I'm hoping that at the least we could do that ineligibility by income, because that I think would largely answer the question for us. And yeah, I'll just flag that as another really important one. You know, I want to understand that population a little bit better alongside, you know, understanding why folks aren't enrolled. I do tend to go back to the kind of administrative friction concerns, and probably the part of that is like with my marketplace hat on, you know, that's something there's control over and then there's work that can be done. But I do think there's affordability reasons, particularly in the marketplace eligibility category, potentially, you know, that's a component for some folks, you know, want to acknowledge that there are people who come in and they look and, you know, feel overwhelmed, whether that's true affordability concern or perception of affordability. That's something to understand better too. Then the last slide from this section on household health spending of this full category, the non-elderly and mean by income group. So this is comprehensive of all spending on premiums, out-of-pocket costs through insurance, as well as direct pay for either uninsured individuals or non-covered services. And this I thought was really interesting to see. I initially just got the sort of dollars per household, then I had asked them to layer on that percent of household income, actually expecting a slightly different result. I have to say, I wouldn't say I was taken aback, but I thought it was illuminating to see the percentages of household income for those 138 to 200% and 200 to 400% of FPL exceeding 10%. Definitely very concerning. And again, from the perspective of thinking about, where are portions of the market kind of ripe for intervention, or for thinking about that those are a couple categories where that's, an enormous burden on households in those income ranges. Not that the others aren't significant too, but again, seeing those up above 10% is quite surprising, not surprising, but sobering.
Do you know where it is now off the top of your head?
I don't.
And so healthcare spending, that includes out-of-pocket costs and coverage, or?
Yeah, okay. So both premium and out-of-pocket. Got it. And this is inclusive of individual, small groups, sort of all markets. Katie, you had a question?
Just a quick question. Do we know if there are any targets or benchmarks nationally related to what percentage of spending is appropriate? Like we hear 30% for housing is sort of a standard. So I'm curious if there's anything on the healthcare space.
That's a great question. Not that I'm aware of. I know there's been some work done, and Connecticut is the state that comes to mind, on what they called, I think, an affordability benchmark, where they were trying to think about sort of what's an appropriate amount to aim for. I need to revisit on that, and I don't think it was as simple as saying like 8% is the standard. I think that they had some variation based on a variety of sort of local geographic factors, but that's really the only work in that space I can think of off the top of my head. I will say it came up actually as I was working on the definitions. Like everyone comes back to this concept of affordability itself is very difficult to define and so subjective. And I think that that's what folks have run into when they've tried to think about this. When I think about premiums, for example, there's the 8-point-something%, or maybe it's 9 now, that the federal government sort of said, like that's the amount that we are setting as what we expect consumers to pay out of pocket. But obviously that is or expect to pay for their coverage, but that's limited to premiums, not out of pocket costs.
And that amount change, well, at least for the premium calculations based on your income.
Yeah, that's the other piece I do think.
8%, somebody who's like barely making ends meet is different.
Yeah, I think the same way that, of course, the percentage varies in terms of total amount based on the income range too, but that also $10 in certain income rates is going to be drastically different and more challenging maybe even than 50 in another. So it's a tough one to land on.
And this is actual out-of-pocket spending. It's not like the total deductible that they could be exposed to.
Yeah, no, my understanding is this is like total projected out, actual out-of-pocket. And that I had double checked just to make sure that it is inclusive, like I said, of those it's not just through insurance, it's also, potentially for an uninsured household in that lower income range, inclusive of their spending. Jeff, Jeff, I saw your hand and then it came down. I just wanted to double check if you wanted to say something or if your question was resolved. Oh, you're on mute.
Of course, I'm on mute. Been doing that a lot lately. So I think I read the notes a little closer. So this costs are netted down for tax credits and subsidies, right?
Yeah.
Okay. I thought.
Yeah, this should be representative again of like actual money coming out of the pocket of the household. Sorry, Jordan.
Oh yeah, just 2 quick questions. Are the horizontal bars, are those like the mean or median, or are they just flags or something?
Yes, yeah. I should have double checked which it was. I'll have to get back to you on whether it was mean or median, but sort of average across, although probably a more typical technical term than average.
Yeah, and then trying to make sure I'm reading this right. For the above 400% FPL, so that's saying that they're projected to spend, it's per person within household.
Yeah.
So household income would be like 10 times that, so like 40,000, is that right? Am I reading that right? Like if they're projected to spend $3,500,
Yeah.
like per person, and the household income, that's 8% of the household income. Then like the total household income is like, I don't know, like 10 or 12 times that, is that right? Or is it like per individual within a household? It just seems low, I guess, the household income figures.
So I think it would be, it's dollars per person within household. So I think in a case where it was a single individual household, that would be correct. But if it was a multi-person household, that you need, you would need to know the number of individuals in the household, multiply that by the dollars, and then by the, consider what percent of the income. You understand? Like that was not a very clear way of explaining it.
No, it makes sense. It's cool that they're able to like model like household sizes too. I didn't know they could do that, but yeah. Okay, thank you.
I think that may have been, the last slide. I did want to ask, because this was finalized very recently, and I just wanted to kind of share it and start to socialize it. The urban team weren't able to join. If there's interest, they're open to coming to one of our meetings and, being able to dig in a little bit deeper. So maybe I won't put folks on the spot now, but, if there's interest in having those conversations, maybe after I've shared the report, if you could let me know, because I think we could set them to come to one of our future meetings and talk a little bit more about methodological questions or sort of next round of questions to work through on this.
Like in their model, can they address small group parameters and moving the definition of small group to 100 and what that would do to small group, assuming level funded participation stays. I mean, they will probably have to fix, certain variables as constant, but interested in what they would, how they would perceive the impact on the small group market, as well as the large group market.
If the definition were moved from 50 to 100. I can definitely ask that. I imagine they have the capability. I think I will say projects for the modeling, it's not as simple as kind of just like go in and move a few things around. So I'm thinking about like the next iteration and what we might want to work on them on them. That'll have to be a defined agenda, but I could ask them about the level of effort involved. And I would imagine that they have the capability. So moving on to another sort of in the works set of analyses and one that I have some next steps I wanted to share with the group. I wanted to revisit this sort of list from our October meeting that I have referred to as phase 1 spending analysis, because I just want to keep making clear options are open. Hopefully there's lots more work to come, but in terms of what I'm trying to focus on accomplishing for 2024, I had made one addition to this. I know Katie had raised, I think in our last conversation about this, some concern about the costs, again, input costs, being what I'm referring to there, kind of not being reflected in the spending. So I did want to put in a placeholder. It's still early thinking, but around finding ways to track and account for costs. I specifically said hospital costs here in part because I'm not sure that there is available data or a reasonable way of doing that, like for providers writ large. And these are just a brainstorm, but that's some initial thinking, and just wanted to kind of flag that that's something in the longer term that I'd like to revisit, talking about how we might layer on, because I definitely understand the desire to kind of like contextualize overall spending with information about costs related to providing care. So wanted to flag that, but then really for today, focus on these kind of first two related sections around measuring spending and trend and analyzing that spending in ways that hopefully are informative for policymakers. So I have been working with MHDO, and I don't know why I wrote MDHO, so sorry about that, Maine Health Data Organization, that's my typo, to work on annually replicable and interactive dashboards of information. So definitely have a foundation for this in the baseline reporting that Karen Lee and team have already done and did prior to the office's establishment, but trying to think about how to layer on to that reporting and other reporting done by MHDO in ways that is relevant to policy questions that we and others are asking. So just a quick note on kind of my formatting here. I wanted to envision like what would a pretty good comprehensive first set of dashboards look like. And several of those already exist in MHDO products, but then there's some add-ons, and those are the places where I bolded and underlined. So you can kind of, see where we may just kind of pull in existing work products and maybe refine them or try to think about display of them, but where essentially a lot of the work has already been done versus some kind of new analyses. And I think I mentioned during our October meeting that we were selected for a Commonwealth Fund Technical Assistance Program. So working with Baylett Health and Michael Baylett, who's been involved with several of the states that have cost growth targets and are doing reporting to kind of think about best practice in this space. I think actually this model hopefully goes a little beyond at least what's publicly available in other states, but trying to sort of take on those learnings from others about what is feasible and most helpful. So I'll just quickly maybe run through here spending by market and medical and prescription drug benefit that really mostly exists in those baseline reports. Would like to add on, especially for the medical spending, service category and maybe refining service category a little bit, and then adding that price utilization intensity analysis that we had talked about at the October meeting briefly. And I've cited some national work using that model. So Healthcare Cost Institute that has their own database of national payers and uses their claims data to perform this kind of analysis. So that would be, I'll say, an inspiration, not necessarily the exact methodology, but conceptually trying to look at spending and rather than just looking at trend over time, asking ourselves, okay, are the drivers of that utilization, which would suggest, I know there's been a lot of conversation among this group that our older population means that we're likely individuals are needing more care and utilizing at a higher level. The price of the service, so again in this context, price meaning what the payers are actually paying using that claims data and the combination, I guess, of total allowed amount, so both what the payer is paying and the consumer out of pocket. And then that intensity measure as well, which is the most challenging one, but hopefully we can get there, which kind of begins to account for the intensity of the intervention, so slightly different than utilization, but distinct from price.
And if I jump in, I think there are going to be instances that kind of cross all three of those. So I know this is more pharmaceutical and you're going to get to it, but as an analogy, Humira and Humira citrus free, it's a great example of all three of those where we saw just a sea change in utilization of the much more expensive Humira citrus free, which was introduced to the market really to avoid the drop to generic and maintaining that patent, et cetera, but it put a big hole in the side of the budget for a lot of payers and purchasers. Just as one example, where really need to dig into the details to understand what's going on, what's driving the utilization of a particular thing that is priced much higher for something that is much more intense because we have seen inflammatory conditions just continue to increase.
Mm-hmm. Yeah, absolutely. And I will say, I don't think this is a dashboard that I expect to put out and answer every question, right? But I think it helps illuminate those conversations so that you can see. I'm sure there will be times when all three are moving together. There may be times when all three are moving, decreasing together, and there may be others where there's a really drastic, kind of differential and delta that starts to emerge. So it's just, to me, it's a helpful way of just kind of, again, peeling back to another layer that allows us to have more in-depth conversations than just looking at spending overall, where there are so many considerations that it can be hard to even really have like a substantive conversation about causes. Jeff?
Yeah, thanks. And I think that was Kevin who spoke about pharmaceuticals, and certainly echo that. It seems like big pharma is winning, and it's not helpful for, frankly, as Kevin put it, the insurance companies, the purchasers, which obviously our hospitals are, play a big role in that. The other thing I want to, mention here, I do love the focus on the numbers because I am a finance guy at heart, but at the same time, I think it's going to be really important to understand and come up with a way of measuring patient access. As a highly rural state, as reforms are implemented and policy changes are made, it could very well create some healthcare deserts or make some of the ones that exist already worse. So I think that's a really important aspect. I don't know the answer to how to measure that, but I had a really great conversation with some of the folks in our maternal medicine group earlier this week. We were looking at a new model coming out from CMS that'll be run through the states. And that was the really big concern coming out of that group is, how do we address and make sure that we have services in parts of the state that might not look financially viable. So important, I think, that we focus on that as well.
Yeah, totally hear you on that. I think, the claims data and the complexity of like accessing that and starting to work in it, I wanted to get that work kind of off the ground and going. So that's part of why, some of my focus has been on outlining what that looks like, because I think it will be a many-month process to get that going. I think my last bullet point here, I agree with you and very much want to be able to do this kind of spending work right alongside quality and access tracking. I think I said in the last meeting, I think having a baseline for that and agreed upon, set of measures for that is really important. I will say the question about kind of inventorying the sources of data that we have now and trying to make use of those, that's sort of my next round of work, I would say, on that bullet point, wanting to revisit that and think about, BRFIS data, working maybe with licensing or others. I think it's a great flag. I had thought a little bit more about like individual measures of patient access, but the more systemic, like where geographically our service is located and trying to track change in that, I see value in as well. But I guess I would pose the question to the group, and it is a really big one, so maybe this is one we can revisit at a future meeting too, or Jeff, I'm happy to also have some on the side conversations with you about this. Like, I would welcome if there's thinking from this group about what those measures should be and sort of like how to access data on them. I think that that'll be a big and a challenging conversation, but one that I welcome feedback on as well, because directionally definitely on the same page with you there. I see Katie with her hand up and then Renee as well. So let's go to Katie first. I think I saw yours pop up and then we'll go to Renee.
Thank you so much. And thank you for Jeff for raising that, and Meg for your understanding of the importance related to access. I actually have a technical question as it relates to the data that you're talking about. I heard you mention the Healthcare Cost Institute, which is a private entity that doesn't make public its data. Are you a member? I guess I have concerns about using sources of data that are not publicly available.
So this wouldn't be HCCI data. This is all MHDO claims data. So working with their vendor and their data set. The reference that I made to HCCI was like a methodological inspiration one that they, with their claims, have done analyses of price utilization and intensity. So it's not about using their data or even frankly like their exact methodology. I was just pointing to that. I know it helped me to wrap my head around like what does that look like and how is it useful. So just sort of the, seeing that, I thought it was a helpful way of interpreting data and more about using that kind of model rather than tapping into their data or anything like that. This would all be through Maine Health Data Organization and HSRI, who's their vendor.
And do the FQHCs or the private primary care groups or others report data anywhere? Because it feels like that's an important aspect, particularly as we look at access in rural Maine. The FQHCs are a critical part of the infrastructure. So just wondering how we could incorporate them into all of this work, not just FQHCs, but also the private providers as well. Is there a way to do that?
That's a great flag. Were you just agreeing, Kevin? I just want to comment.
Well, I was just going to respond. I know that FQHCs report extensively to the Health Resources Services Administration. So
right.
The UDS data is among the many different data sets that you can find information on.
Yeah, that's a great flag. So happy to take that back and make sure I understand it a little bit better and think about ways to incorporate them as well. Both, I think, on the spending side, but definitely on the access side as well.
Thanks.
Renee?
Yeah, so just to answer that, so the UDS is something that all FQHCs need to report all their data to, and that's publicly available. We're actually getting that data ready right now for 2023, and usually it's publicly available by July. So you can see the 2022 data for every health center in the country. So there's that, but I just wanted to go back to the access question, which I think is really important. And what I would love to try to be able to figure out is, where does lack of access drive healthcare costs up? And where might having different resources that are maybe only in certain places, where does that drive things down? And trying to think creatively now that we're all very used to providing care electronically. Like, I think that I think I have some assumptions about that, but no data. And I wonder if there's any way to get data that would help us drive recommendations about what kind of access across the state is going to be helpful to the patients, but also affordable. And then what kind of access do we need to potentially be thinking differently as a very rural state, with a couple of hubs of larger healthcare centers?
Yeah, it's a great question. My initial instinct is that it may need to be almost like a separate standalone kind of work product. I think there are so many confounding factors in a question like that I think it's hard in like a dashboard model to try to answer it. What I'm thinking is, like, certainly we know there are some regional geographic differences in spending and probably to some extent utilization across the state, but understanding whether that's driven by factors like higher rates of poverty in certain parts of the state that may, cause more, that sort of generate more need for health services and lower health among the population, versus whether it's actually connected to, for example, difficulties in accessing primary care. I just think it's going to be hard to kind of capture, but I think it's a great question and one that might make sense to kind of overlay on this regular recurring data reporting as maybe a special kind of special ad hoc report for planning purposes. It is something I don't know if anyone knows off the top of their head, but it's a connection I can definitely make and reach out to, whether the folks at USM at the Rural Health, I think it's Rural Health Research Institute. I mean, I know they've done some environmental kind of scans and some work around issues like that in the past in Maine, though the most recent may be a little bit older, but it might be an interesting topic to kind of approach them and see if there's any interest in collaborating on. And just curious, is that when you say you have some ideas around this, I'm just curious if there's more you want to say about that in terms of whether it is delayed care in lower cost settings, or I guess impact really of delayed care. That's more my question is, are you thinking more about folks sort of not having regular care for chronic conditions or early intervention, or is it more about like the site of service due to lack of kind of available different sort of maybe non-hospital settings? Just interested if there's any particular directions to kind of focus on.
So I think it's probably both. I think it's probably a combination of people who don't have access to care and then end up, you know, very ill in a hospital, but also people who don't have access to care. So instead of going to primary care, they go to urgent care, or they visit the emergency room, or the emergency room becomes their primary care practice. So I think it's that's why I'm interested in knowing, you know, actual data, because I don't know if any of that bears out.
Yeah, it's definitely good food for thought. I'll take that back and try to turn it over a little bit more and try to think about whether, you know, I can at least try to like outline a methodology for how you would try to think about looking at all of those factors in isolation and actually controlling for the population, since I think that, as I said, I think that's the hardest part in my mind. So yeah, happy to take that back, but I guess I'm not saying impossible, but I think it's helpful to maybe think about that as, like I said, a different work product. And I should have said this at the beginning. I mean, this is not by any means intended to sort of like be the only output of the office. I really see it as a foundational piece that again can be repeated each year. You know, begin to monitor trend and sort of be something that we can revisit. But there's a lot of other, I think, policy questions that you know, can be answered, and that there's value in trying to maybe either use this data to interpret or to report out on, or even thinking about, again, ad hoc analyses, pulling in different data sources, which might be necessary with a question like that.
MHDO calculate like a population risk score by market and look at that over a trend, like are people getting sicker? I mean, you'll get some of that in the intensity measure, I think. But we do a retrospective risk score for at the employer level, and it's helpful to understand sort of where the costs are coming from.
Are you using claims?
Yeah,
for that?
yeah.
I would imagine then it's possible, yeah.
I don't know if others think that would be valuable, but you know, there's an assumption the population is getting sicker on the whole.
Would it deflate though, like risk scores in the areas that like lack access, just because they don't have claims at the same volume as like other areas when they kind of, I think it's still a useful metric, but yeah, if you're not capturing, like, you're capturing actual utilization, not like needed utilization, right?
Yeah, yeah. I suppose you're right.
Yeah, that's interesting. I'd love to learn more about the methodology for that, even, and whether it incorporates in, you know, any aspect of that, like what's the impact of deferred care? I mean, I guess if ultimately we're asking a question about like what is the cost impact, then yeah, claims should be able to answer it, but it's a good point that it's not gonna be the whole picture. So happy to dig in on that more and ask, but not something that we had discussed in sort of this element of the project, so maybe something that makes sense to add later.
Sure.
Any other, we've sort of gone through it, so I won't keep reading through the list, flag just trying to get a few levels deeper on DRG, CPT codes, and then again, revisiting this quality patient access measure. So definitely that'll be something that I'd like to come back to this group with maybe proposals on and have an opportunity to discuss and get feedback and ideas from all of you, but have sort of phase that a little bit later, because I do envision that being something that's a display and aggregation of existing data sources rather than a sort of custom analysis for the office. I'll be very brief here. I just thought I would include it. Rhode Island has this Office of the Health Insurance Commissioner data hub. That was one of the states that I was looking at when thinking about what might be helpful to display. I just did a screen grab here, but you may want to go and look through all of their displays are also interactive and can be filtered in a variety of ways. I think there may be some display things, like I think it'd be great to do more of like a trend graph here rather than the table with this, but just to kind of call out their reporting on per member per month costs, per unit costs, and then utilization per 1,000 in each of these 3 columns, and then reporting out on the % change year over year in each of those categories. So this is high level, just doing medical and drug spending by each of the markets that they track, but just to give a little bit of like an illustration of what I'm thinking about when thinking about this analysis. I'll move on, even though I see Trevor expecting to look sorry. I can't answer questions about their analysis off the top of my head either, although I will say I think they're one of the states that I was thinking about reaching out to maybe come to one of our meetings and chat. They've done a lot of work in this space, both reporting and then some interesting work kind of through their insurance review model around affordability. So if folks want to look at that one and it works out to have their commissioner come, could have an opportunity to chat about their decisions around the data too. So then, a little early for today, but I assume others won't complain about that. But my last slide's just closing up and thinking ahead to our April meeting. A few agenda items, as I just said, thinking about inviting speakers. I think if there aren't other items from members in terms of agenda items for that, I'll probably move ahead with doing some outreach and finding out if people are available for that. And then I imagine there may be some legislative updates at that point too, so wanted to put in a placeholder for that as well. But I'll pause there in case there's anything else that folks are interested in chatting about. I will say it's a placeholder, but my hope would be that for the next meeting in June, we might be in a position to bring back a first round, at least probably not all of that data analysis, but an initial round of it to socialize with this group and get questions or feedback on that work. So looking another meeting ahead, but that's kind of the cadence that I was thinking about. Okay. Well, if there aren't other items, I guess we can wrap up and give everybody a little bit of time back, let you maybe squeeze some lunch in. And yeah, I will look forward to seeing everybody again in April and hopefully having some guest speakers, which would be, I think, a fun way to structure the meeting and, think big a little bit, start thinking about that conversation about like, what do policy interventions in this space look like? So we're not just talking about how do we define the problem and measure it, but also what have others done to try to address it, which I think will be great. So hope you all are hanging in there through the rest of the legislative session, and I'm sure I'll talk to most of you, but see you again in April. Thanks all.
Thank you.
Thank you.